Well, so the challenge is we don't have the crystal ball to look down the line. But what we do have is a lot of data about what early intervention tells us, right? So when we get started earlier, we do find that many of those quote unquote negative behaviors are mitigated or lessened as the kids get older because they've had that support. So now their confidence is stronger, their awareness of whatever challenges they had start to sort of dissipate. That gap actually gets closer together instead of widens, as long as the kids have been successful earlier on.
Hey Joleen, welcome to the Authentic SLP. How are you doing this morning?
Hanging in there. Thanks so much for having me.
Sure. So I just want to go ahead and start, just jump in. Tell me a little bit about your journey and who you are and your story.
So, yeah, that's a great question. I have been a speech language pathologist for nearly 30 years. I was originally headed to Broadway. That's what my goals were. I wanted to be a performer. And then I think reality hit, and I made the decision that I didn't want to go work for peanuts and live in the city. And so I had a colleague who recommended being a speech therapist, and I really had no idea what that meant. So I shadowed her for a day and just fell in love with it. And that was when I was 16. And so I guided my whole, rest of my high school career, and then of course undergrad. And I am of the generation where you only needed a bachelor's degree for your certification, your licensure as an SLP. And it was my senior year of undergrad that they changed the requirements. So then I needed to go for my master's. So I did my master's degree. And my original plan had been to focus on supporting speech sound disorders. That was my passion. And then I had a daughter who had selective mutism, and that's an anxiety-based disorder. And so in trying to find support for her, I discovered that it was an area that really needed a lot more research. It needed a lot more support. And it seemed like the speech language pathologist was starting to get more and more involved in treating kids with selective mutism. So I went back for my doctorate, and I got my PhD in infant and early childhood development with an emphasis in mental health. So I could have gone on to be a licensed clinical social worker, a mental health counselor. I could have even gone the psychology route, but I really didn't want more licensure, more certifications to keep an eye on. And so I shifted gears to just focus most of my practice on selective mutism with a sprinkling of autistic, neurodivergent kids, including speech sound disorders here and there.
Wow, interesting. So you're kind of like a speech language pathologist, but heavily understanding the psychological part of it.
Yeah.
Which is so important.
Yes, absolutely. I would say I am not your traditional SLP for sure. Through that part of my journey, I also learned about DIR Floortime. So one of the things that I had started with my daughter was trying to kind of meet all of her needs. We didn't have a lot of research back then, not that we have a lot now, but we definitely didn't have much back then about selective mutism. And so I was sort of like playing whack-a-mole, where I was trying to hit on every single type of challenge that she was experiencing. So that social emotional side, the sensory processing, the motor planning, as well as the social pragmatics, language side of things, and the direct speech expression side. And in doing that, I didn't realize, but in doing that, I was really providing for sort of a whole child view, a whole child lens. And that wasn't my background in speech. I had always sort of been taught to look at a particular symptom, one area of language, and sort of be more tunnel vision from a top-down type of approach. And so in my PhD time, I discovered DIR Floortime and realized that essentially what I was doing with my daughter was truly providing DIR Floortime. I just didn't have the training in it. So then I pursued getting certified as a floor time expert, and now I'm a training leader. So I actually teach and train other people interested in getting certified. And so now my whole practice, like I said, is selective mutism with those other diagnoses, but really under the broader scope umbrella of a DIR floor time practitioner.
Okay, so in a nutshell, DIR Floortime is?
So really quickly, so everything's an acronym. So D is social emotional development. I stands for individual differences. So whatever makes the child a unique individual, right? What makes them them? So that could be their speech and language challenges. It could be strengths in motor. It could be that they're sensitive to gluten. It's really whatever makes them an individual. And then the R is relationship based. So everything that we're going to do is founded in that connection and relationship. So that's the D, the I, and the R. And then floor time is really the therapeutic intervention. And it uses strategies like following the child's lead, using big affect and facial expressions, and so on to make those connections.
And who would this be appropriate for?
So most people think that it's really appropriate for autistic or neurodivergent kids, but truly it's a lifespan development model. So I always joke and say that I floor time my husband, I will floor time my own children. I use the DIR framework, again, thinking about people's social emotional development, their unique individual differences, and then what is my relationship like with them? Are they a good fit for me, and vice versa? I can use that in friendships and relationships across the board. My staff, even, in my practice. So that the truth is, it's birth to death is really who it's appropriate for.
And you used it for your daughter with selective mutism.
I did. Yeah, I found that was a much better model. It reduced her anxiety. It really helped build that internal confidence as opposed to sort of that extrinsic, outward, goal-driven type of personality.
Yeah, and I think so many of our kids too, that anxiety is a kind of at the root of a lot of these things. I see it more and more and more.
Absolutely.
So recently you started a school. So tell me a little bit about that, and then your private practice. You do a lot. So I know
I do. I wear lots and lots of hats. Absolutely. I mean, and I will say that the common thread through all of them is that DIR Floortime philosophy. So the school is called Reconnections Education Center. And if people see the word Reconnections spelled out, they'll notice that the R, the E, and the C are all capitalized in the beginning of Reconnections. And again, everything in our field is an acronym. So when I talked about the DIR model, that social emotional development for the D, the first three capacities of social emotional development are regulation, engagement, and communication. So that's the R, the E, and the C in Reconnections.
I love your school so much.
So it's very, foundational on those three capacities because you need to be working at that foundation of regulation in order to engage. And then when we're engaging, then we can get to that communication. As opposed to let's do, for lack of a better term, drill and kill, like flashcards and so on, that we used, I would say, in the old days, although I do think that there are some SLPs that still use that model. But a long time ago, that was really all we knew. And so we thought that by using flashcards, that was going to transfer over to functional communication. And the reality is that it doesn't truly. It's great for capturing data, or it's great for that one particular activity that you're doing, but it doesn't often generalize into a broader communication situation. So the school is founded on the philosophy of regulate, engage, and then communicate, using a very intrinsic philosophy. So we want the kids internally driven, Many of them come to us with very negative school experiences, very traumatic school experiences. And so we work really hard to help them understand that school can be a safe place. School can be a comforting place. It can be a place where your needs can get met and you can feel really comfortable showing up day in and day out. And then when things aren't comfortable, we're going to work through that. So we have a 1-to-3 ratio, which is, I'm pretty sure, almost unheard of.
Yeah.
So for every 3 kids, there is a classroom teacher. So the most students in any one room itself is going to be 6 kids, and that would be 2 teachers in there. But typically it's only 3 kids with the 1 teacher. And then we have what's called floor time players, which float around. So if kids need a break, for example, they can come out of the classroom, head down to the gym, be on the swing or the trampoline, or we have this amazing rock wall where they can use those tools to learn how to re-regulate themselves and then get back into the classroom for learning.
Okay.
And then, yeah, go ahead.
Question.
Sure.
Just if I was a parent, okay, and I'm debating, and this is authentic, so to be honest. Okay, my child to go to public school or something like Reconnections. Why is it worth the investment in something like Reconnections compared to a public school program? Without putting them down too much, but the differences, and then like you talked about the regulation and connection, and then what can happen to these older kids if they aren't at a young age put in a place where they're not connected? What happens?
Great question. So being strengths-based, I will do my best, but the challenge in the public school is that typically there are, let's say, 25 students in a classroom, and out of those 25 students, you have 1 teacher who's trying to differentiate their instruction to hit every single one of those 25 students. And so while the teacher may be a master educator and have amazing skills, it's literally impossible to teach 25 students where you may have 3 to 5 students out of those 25 that have a very different learning profile than the other 20, let's say. So what happens is in public education, the teachers have to teach to the majority in the classroom, right? That's just how it works out. And so they're hitting maybe 18 to 20 of those students, but there's another 5 students that probably aren't getting their needs met in the public education setting. So that's one piece that I would say is different between the two. The other thing has to do with the related services that you receive in a public school setting versus what you would get with Reconnections. So in a public school setting, you have your individualized education plan, an IEP, and that IEP specifies what that child's needs are. But remember, in a public school setting, you've got 67 kids on your caseload, sometimes more than that, and still only 30 some odd hours a week to be able to provide services. So that means, let's say just for the sake of math, each kid is now getting 30 minutes of speech therapy, maybe 30 minutes of occupational therapy, because most likely those schools are not able to staff more than 1, maybe 2 therapists, right, in each of those disciplines. So that child now is really getting only education-based goals in their treatment plan, whereas at Reconnections, we're able to look at practical life skills. We're able to listen to what parents' needs are in their home environment. You know, they want their kids to pick up their laundry from the floor because that is a huge barrier, right? So whatever their goals are, we're able to build that in. Whereas in a public school setting, the expectation is that those goals and objectives are very educationally based, right?
Yeah.
So I would say that's a huge difference between us.
And I think too, what I see when I was in the public school, and like I said, every kid's different, every parent's different. It depends on what's right for every family, but what I didn't like seeing was the drilling of the same concepts and the not presuming competence of children and what that does to a child's mental health. And that's where you come in. So, and then why then these negative behaviors come. And
Absolutely.
that cycle is a huge thing that I would love for you to speak on, because if any parent is going to listen to this right now and they have a 2-year-old or a 3-year-old that might be, struggling, and they're kind of guiding where that kind of advice of the presuming competence and making sure that the people in their life are also seeing that child for that. So, go ahead.
Well, so the challenge is we don't have the crystal ball to look down the line, but what we do have is a lot of data about what early intervention tells us, right? So when we get started earlier, we do find that many of those quote unquote negative behaviors are mitigated or lessened as the kids get older because they've had that support. So now their confidence is stronger, their awareness of whatever challenges they had start to sort of dissipate. That gap actually gets closer together instead of widens, as long as the kids have been successful earlier on. But for those students that don't have that success and haven't started early on, it's not the end of the world. So for families that are listening, I don't want them to think, oh my gosh, I haven't gotten my kids services and now they're in 3rd grade and now we're starting to see that struggle, which by the way is really common to start to see around 3rd and 4th grade, because that shift in education turns around from, you may have heard that concept of learning to read to reading to learn, right? So then it flip-flops. So now it's not the mechanics of what they're being taught. Now it's kind of the application and what does that look like? And of course, that's going to require so much more brain power, so much more effort and energy on the part of the kid. And if they're not successful, again, they're typically really smart when we presume competence, right? We acknowledge that they are intelligent, but now they're also so aware that they're not the same as their peers, that their level of reading comprehension may not be the same, as their peers. They're not processing multi-step directions in the same way that their peers are. And so they feel different. They start to feel much more less than, compared with their peers, which then of course cycles into depression, frustration, annoyance, school truancy. They don't even want to go to school, avoidance. And that's where you start to see, quote unquote, all of those negative behaviors. You have kids running out of the classroom. You've got kids throwing things at somebody else in the classroom. You have kids flipping upside down, tables or chairs, getting more aggressive. And then from my perspective, in my lens, I think about what's happening in the brain during all of that, right? What is really going on neurobiologically when kids are behaving that way? And what I typically notice is this overreactive amygdala. So the amygdala is that part of the brain that's your safety system. It's what keeps your body safe. And the idea is that amygdala fires off when it feels like your brain and your body are in danger. Now, it might not actually be in danger, reality-wise, but it perceives that it's in danger. So it fires off that fight, flight, or freeze response, and there's actually 3 more, the fawn, fatigue, and flood response. So there's 6 F words. I call them the F words we can say. And those 6 F words are what are going to cause us to behave in a certain way when we perceive that we're in danger. So those kids who fight, right? They punch, they kick, they hit, they bite, they pinch, they flight, they run out of class, those elopers as we call them, right? They run away. Or they freeze. We have some kids that completely are frozen and they just can't engage, they withdraw. They kind of take everything in, observe their surroundings, right? Mm-hmm. Fawning is when you go around and you kind of go with the flow. You just join in with whatever's going on. Mm-hmm. A flood of emotion. So these are the kids that cry, they yell, they stomp their feet and get really emotional. And then fatigue is when they're literally exhausted from, all of this together combined.
Did you see, is that, sorry, you're saying they around 3rd grade, but I also see this around 5.
I was going to say, and it doesn't have to be a certain age, but you start to see so much more of that culmination
Yeah.
really around third grade when, again, that shift happens in the school setting. But for our little guys who don't understand these big feelings and don't understand this emotion, right? You're going to see that. And here's the other kicker is you see them one way in your household. So moms and dads see a kid behave one way in their home, but then they send them to preschool or kindergarten, and they look really different there because they're accessing different F words depending on where they're located. And that makes a big change too.
Yeah. No, it's interesting. What do you think that if you had to go back to yourself as a parent as a young age, like what advice would you have given you, or what would you have done differently, or what would you say, oh, I did that right? Like what are some things that you would give advice to parents that maybe you wish you would have gotten, if that makes sense?
Yeah, I mean, being a parent doesn't come with a guidebook, right? There's no cookbook, no manual that tells us do this way. If your child does X, then behave this way. So I think for myself, I wish I had understood that the current time is only, this moment in time. It's not how my kid acted when she was 3 does not impact how she acted when she was 13, and it doesn't mean how she's going to act at 23 or 33 and so on, right? So to really take a step back and understand that this moment is truly a snapshot in time, and that we need to give ourselves some grace for our moments. I think I was going to say all parents, but definitely most parents, we overreact in certain circumstances, right? We may yell, we might use our big voice, and I think for me, I used that a lot. My kids used to say I had a Miss Hannigan voice, if you're familiar with Annie. The musical, Miss Hannigan was, the mean, kind of screaming, yelling lady at the orphanage. And that's how my kids describe me. So clearly I yelled a lot. So for myself, I would say take a beat and take a breath and
Definitely emotional regulation yourself.
For myself.
Make sure I guess as a mom, your self-care, and give yourself self-care and your therapy and what you need to do, because you can't regulate your emotions. Your kids are probably not going to regulate.
Correct. Yeah.
And that's not easy to do, especially as an adult.
No, I mean, in floor time, we talk about we are the calm, right? So if you think of it like a teeter-totter or a seesaw, you've got, your kid who's way up here. Well, if you join them up here, they're going to just keep getting bigger and bigger and bigger. But if you can be the seesaw where the child starts to go high and you go a little lower, they're going to come down to your level, and then you guys can come down together. But again, if you are a personality who's got a lot of big feelings yourself as a caregiver, you're going to keep going up, 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 and up. And before you know it, everybody's screaming, everybody's crying, everybody's, amygdala is in this fight or flight state, and no one is getting any of their needs met in that moment. So yes, take a breath, think about being the calm for sure. And then I'm trying to think, for me, just enjoying being a caregiver, like just enjoying the moment and being present in the moment. I think for so many of us, we get caught up in technology nowadays. I always watch moms and dads walking the neighborhood, pushing the stroller, which is great. The kid's getting outside and some fresh air, but then the parent is on their cell phone while they're pushing, instead of talking about, look at the leaves and look at the grass and, oh, I see a squirrel, which builds beautiful vocabulary and beautiful engagement and interaction skills. But if it's all one way, where the kid's kind of pointing out these things and mom and dad are like, yeah, oh, good, yeah. There's nothing really to draw from that. So I would say be present with your kid and hang in there. Yeah.
Give yourself grace, because it's hard to figure it out. And that's why I think that first 3 years are so important, because you just don't know what you don't know.
Right.
And so you have to learn fast. Yeah.
It is. It's a quick learning curve, right? Again, nobody gives you an instruction manual. You're thrown into this situation. And if you've got a neurodivergent child who is not developing along that typical trajectory, that gives you even a bigger curveball that no one has any instructions to help you with.
Now it's like 1 in 32 or 1 in 33 kids have autism now. Yeah.
Yeah.
It's becoming, I think so. Just that it's possible that your child is going to have some challenges. And emotional regulation is so important for all
Absolutely.
kids, especially them, because they take on our emotions.
Yes.
So let's see here. I'm going to ask and see if this is a good question, but do you see links between selective mutism, autism? Are you seeing any links between all of these things with the increase of 1 in 32? Like, what are your thoughts and increases? I just like to hear people's opinions on all this.
Yeah, well, I have opinions, but I also have research to back them up. So I think that's always a beautiful thing, right? When we talk about our evidence base. Yep. So back in the early 2000s, the prevalency for selective mutism was 1 in 143. At the same time, autism's prevalence was 1 in 150. So back in the early 2000s, SM was actually more prevalent than autism. Now, we have not had any more prevalency studies in selective mutism, but of course we've had all of those in autism, and we know how drastically that ratio has shifted, right, to that 1 in 32 kids. So my assumption is SM has also increased in prevalence. Almost my entire practice are kids with selective mutism. So there's definitely no shortage of them. Now maybe they literally all come to me, but I'm sure that's not the case. So I would assume that there's quite a few kids, especially knowing what we know about anxiety these days too, right? The mental health state of our world right now is pretty we are on the struggle bus for sure. So as far as that goes, I think that the prevalency is there. Now, as far as the connection between SM and autism, there have now been a number of studies that actually show a higher rate of incidence of autism in kids with SM. And then we have our autism statistics that show what's called situational mutism, where our autistic kids and adults get into social situations where they're not able to access their words, even though in other situations they have been able to. So right now, because we use the guidelines from the Diagnostic and Statistical Manual, that's the diagnostic manual that people use when you get an actual diagnosis. It specifically says that if you are autistic, you can't have selective mutism. That's actually what the DSM says. However, the real world is definitely showing us that they overlap significantly. And some of the most recent research shows that as high as 60% of the kids with selective mutism are also autistic. And again, autistic people experience situational mutism all the time. So I think that they're very highly linked. And to me, that makes sense when I go back to that neurobiology, right? You go back to that amygdala. The brain is the brain in whether you're autistic or whether you have SM. And that shutdown, that fight, flight, freeze is going to kick regardless of whether you're, autistic or, with selective mutism. So definitely an overlap to be aware of for sure.
Yeah, and the DSM changing for autism, I think definitely has. Now it's a lot. It's a lot.
Well, it encompasses so much, right? It's so broad that, it's almost, you would be surprised if somebody didn't meet the criteria as being autistic.
I know. I hope that there's going to be some changes there, because I think there needs to be, but we'll see.
Yeah.
All right, let's talk about a little bit. So back to what are some things that parents should do? We talked about emotional regulation and all that, but like, if you notice that your child may be having some challenges, maybe on the
Divergent.
I don't know why that just lost everybody up. Neurodivergent kind of spectrum at a young age. What are some things that you would say, invest your money in this, and this? Like, it's worth to pay a little extra for a speech therapist that does this, or an OT that does this. What would your major things that you would say, do this?
So the challenge is, I think you do almost always get what you pay for, right? And so sometimes our insurance access limits the different therapists that we do have access to. So if you're a caregiver and you're starting to see shifts in your child's behavior, or you notice this discrepancy between how they act at home versus how they act when you're out in public at the grocery store or at the library or at the, gymnastics class or whatever, but you're noticing some differences, go with that gut and find a provider who will listen to you. So sometimes that can be a person that your insurance accepts, sometimes it's not. But if you go to your pediatrician and your doctor says they're just shy, they'll outgrow it, use that inner Jiminy Cricket, as I call it, right? Your conscience to say, no, this doesn't feel right. This doesn't feel like they're just going to outgrow it. And maybe they will, but I'm not willing to take that chance, right? I don't want to risk it. And so to make sure that you find somebody that's willing to listen to you. Now, just because they listen to you and they understand you doesn't mean that they're skilled in whatever it is that's going on. So then you need to be able to ask lots of really great questions about their experience, that provider's background in working with young children. So when my daughter was diagnosed with selective mutism 21 years ago, almost no one knew what to do, literally. I mean, we have come a long way, but almost no one knew. And I certainly didn't know anything then. And so I started calling different therapists that I thought would be the ones that would help support my kid. And all of them, many of them, were saying, we don't see 3-year-olds. We only start at like 8 and 9 when the kids can, have a dialogue with me and whatever. And I was very sure that early intervention, whatever that looked like, but I knew earlier the better, right? That was the, kind of drilled into my mind. And so I just kept going until I found the support system that I needed, but that even more so my kid needed, so that we could move forward from there. And having people who are experts in like adjacent areas, I think, is also key. So trying to find a speech pathologist that had background in, anxiety or mental health, that was, again, almost no one back then. So I knew, okay, a social worker, a licensed clinical social worker who does play therapy and maybe uses the sand tray is going to be a better fit than, a psychologist who's going to sit and ask my daughter what her deepest, darkest fears were. That wasn't going to happen. So we went that adjacent route where I could have the social worker play in the sand with my daughter, and that was just as therapeutic as a psychologist who typically saw older kids who would, again, share those worries and fears. So sometimes it's a matter of kind of knowing what's right next door if you don't have access to everything right there in front of you.
Right. And I like a few things that stood out to me too is using your intuition.
Yeah.
So even when the pediatrician says that, wait it out. And like I said, I love pediatricians, they just got a lot on their plate. That if you still feel like something's not right, an evaluation doesn't hurt.
Correct.
Okay. And then also finding those right providers. And that's why I'm doing this whole podcast, this whole thing, because I am not, selective mutism is not my thing. So I refer everybody to you. So yes, you do get all of our patients, but because that is your thing, and we all can't be good at everything. We just don't have that time, the expertise. So referring to the right people is so important, and finding that person in your niche. Yeah. Because what happens if you don't is that you might go to the person that takes your insurance. This is what I've noticed. For like 5 years, no progress. You paid so much in co-pays, they took your insurance. But if you would have just got to the right person earlier for 6 months, you would have had the tools you needed and your child needed and be done in 6 months and paid less money. Exactly. And again, no one has that crystal ball to really, truly understand or know, is this the right provider? But once you figure out what those challenges are, it goes the other direction. I refer certain kids to you that I don't see because those aren't the kids that I have a strength in supporting, right? So I'm going to refer those kids onto your practice. And believe me, for anyone who's listening, there are plenty of children to go around. There's lots of kids and support. So we're here to collaborate and to work together. Most therapists, I would say, absolutely want what's best for the client, and it makes no sense for you to come to me and work for those 5 years with no progress. That makes me feel badly as a therapist. I don't want that. And so I'm going to refer to somebody who has that area of expertise.
I don't see kids who have disfluency or stutter typically. That's
Yeah.
not my strength. Can I deal with the anxiety side of that? Absolutely. And support that for sure. But the other side of that, I don't treat like traditional stuttering, but there are other therapists that do that. Same with feeding therapy. There are other therapists that really specialize in feeding, and that's just not my wheelhouse. So finding that person that's a good fit for you, I think is key. I don't know if every clinic, so I don't know how you do it, Nicole, but for families who come to me, they meet with me as a consult, quickly. We try to then, because that weeds out, am I a good fit for you or am I not?
Yeah.
And who can I refer you to if I'm not, right?
Yeah, I love that. Yeah,
So,
we kind of have the same process coming in where we kind of screen them on the phone and then
exactly.
we're out if we're not the best for them. Yes,
Exactly. And sometimes you probably get them in the door thinking, okay, we're going to be a good fit. And you do that evaluation and you're like, mom and dad, I really don't think that this is going to work for us. These are the challenges that I see. I really think you need to see a play therapist. I really think you need to see this special, feeding person or whatever. These seem to be your bigger concerns. And I think that speaks volumes about the type of professionals and clinical expertise that therapists have, that parents want to be aware of as well.
Yeah. I think being practiced for a while, it takes a while to get there. Sometimes the younger ones, they think they can help everybody, which is great, but there does come to a point where it's good to refer out. So.
Right. Yeah.
So speaking of that, just kind of wrapping up here. So I kind of know what you're good at, but tell us a little bit about where, about you and your practice, because I know you have the school and then you have your individual. So who would be a good fit for you? Who are the kids that you guys like to see at the school and your practice, and who would not be besides? You've already kind of given a little bit, but
yeah. I mean, for the school, I think the kids that are really truly struggling in their public education, those are the ones that we want to support.
So verbal, nonverbal, all of the spectrum.
It doesn't matter. It's not diagnosis specific. However, I guess the caveat with that is that it is a financial challenge. So depending on families' financial situation, if their child has a higher support need, then they typically receive greater funds through the Step Up for Students scholarship. If people are aware of that, the Family Empowerment Scholarship for Unique Abilities. So if they have that funding because their kids have higher support needs, they're going to be probably an easier match for us in the sense that the funding's not a burden for them. So that's the biggest piece. But as far as who's great to come in, we take kids who are non-speaking that use augmentative and alternative communication, AAC. We have kids who have language learning disabilities, so it really is a broad scope. We have kids who have seizure disorders, and then kids who have really impactful syndromes that, cross they're on have feeding tubes and so on. So again, it just really varies depending on the kid. And then for the practice, it's really a range of kids. So my private practice, again, a lot of selective mutism, autistic. I would say the kids who have more executive function challenges or maybe more attention deficit, organizational difficulties. Again, those are the kids that my practice sees. And then we're opening a DIR center, and that will be a broader scope because I don't have enough on my plate right now. So that will have a broader range. So people who need the more kind of holistic view of all different therapies, OT, speech,
Okay, I was gonna ask
music
that.
therapy, music therapy, play therapy, kind of all under one roof. That will be part of the center.
So the clinic, you're opening up like a new clinic that's an OT and speech kind of,
Yeah.
and then you guys you're kind of an alternative to ABA. And what's-
Correct. So that, for people who are familiar with ABA, that behaviorally based model, DIR Floortime is sort of the opposite end of that, where everything is intrinsically, internally motivated, no token boards or reinforcement sticker charts, those kinds of things. We don't do that.
So families that want something different than ABA, but still to work on the same type of
So the goals.
Yes.
Yep.
So that's good. That's really awesome. I'm glad you're doing that. But right now, do you have OT now currently?
I do. The OTs for my practice are the same OTs as the school. So their availability is really only after school. So they don't have a whole lot of spots available. And then our plan will be to hire somebody specific for the center as we sort of get that going and rolling. Yeah.
Awesome. Well, thank you so much for your time. I appreciate everything and the time that you took out. I know will help a lot of families. So
Awesome. And if people have questions, they can always reach out for sure.
I meant to ask that. How can they find you?
So my website is joleenfernald.com, and I'm sure you can put that in your notes or whatever, but Joleen and then Fernald, Fernald. So they can, yeah, if that's the easiest thing, and then just go to the contact page and they can email me from there.
Awesome. Thank you.
Thanks so much for having me. This is so exciting.